delighted now to invite Richard Moore onto the stage. If I can get your presentation up, Richard. Here you go. Richard is the business manager for Lee Valley Health Federation. Richard is working with 8 practices in Lee Valley to obviously look at the services that the 8 practices are providing and standardise some of those services, and in particular standardise access and consolidate their services. But he's not only going to tell you about how this is benefiting patients, but also what has been gained for the practices themselves. So Richard, over to you. Thank you very much.
Thank you, Peter. I'm slightly concerned with it. Risk of death by PowerPoint this morning, so bear with me, please. But I am particularly encouraged to hear Chris's lecture, and I'd love to see some bottom-up stuff that's going on in Luton. So I think it's great what we've heard so far. As Peter said, I'm Richard Moore. I'm the business manager for a GP federation in Lower Lee Valley, and I'm going to come and talk to you about some of the things we're doing in Lower Lee Valley, and hopefully it'll sort of ring true with you and think what you can do. So before we kick off, I thought I'd tell you a little bit about us and where we are. So we are a locality. We are one of 6 in Eastern North Herts CCG. We're a fairly small locality. We support a population of about 75,000 people. And geographically, we are a little bit north of the M25. If you go up from Enfield and a bit east from Potters Bar, a little bit west from Enfield, you'll be about bang on where we are. Okay, so what have we got in the locality? Well, we've got 8 of these, we've got 16 of these, and we've got 1 of these. This is a graph of the deprivation levels that the practices in Eastern North Hertfordshire CCG support. What you can see is the horizontal orange line going across the middle is the CCG average. The grey line's just got a thing on it. There we go, the grey line at the top, that's the national average. And the Lower Lee Valley practices are the orange columns. Okay, so you don't need to be a data analyst to see that the majority of the practices in Lower Lee Valley are at the left-hand end of this scale. And what you've got is you've even got 2 practices up there which are quite significantly higher deprivation levels than the national average. Interestingly, we're not all down there. We've got 1 here. So we have got a bit of an outlier, and that practice in Cuffley and Goffstoke is supporting a very different population cohort than the other 7. So what's on the horizon for the locality? Well, we think we've got some challenges coming our way. We've got the local council has got some grand plans to build houses, and we are also looking forward to Crossrail 2 popping up in the locality in 2031. So what does that mean? Well, it's a forecast, and we all know that forecasts should be taken with a bit of a pinch of salt, but we are forecasting a growth in our population of between 30 to 40% in the next 15 years. Going back to Chris's slide, are you a victim, are you a ostrich, or are you an innovator? This slide will apply to no doubt every single one of you. Every single one of you will say, our locality's got the most need, we've got loads of need in our locality, the patients are particularly needy, we're the worst. That's what I was told when I started in Lower Lee Valley. And again, in Lower Lee Valley, we're no worse than anywhere else. I would say we're particularly worse than anywhere else, but, we are struggling. Many of the practices struggle to recruit the resource. We haven't got enough doctors. We haven't got enough nurses to meet the demand. Overall, and I'm being fairly general, but overall within the locality, we are not performing particularly well on access or patient satisfaction. And I've also talked about that, we've got a significant forecast population growth challenge that's coming our way. So the locality thought, well, again, back to that slide of Chris's, it's all doom and gloom. Or actually, should we get up and do something about it? So they did, and they thought, well, to be honest, we want to do something, but we don't really know what to do, and we don't know where to start to do it. So we thought, well, let's start by saying, actually, what is the demand out there? So what's the pressures on us, and what are we doing really well at the moment, and what are we doing that we probably should improve? So we went about doing that, and I'm just going to have a slightly aside. I'm going to talk a little bit about the federation. So in Lower Lee Valley, we have a very healthy GP federation. And I put down there it's a cooperative, a collaborative, okay? And that's what I want to get across. You know, this is very much a cooperation of the GPs in Lower Lee Valley. We have 8 very engaged GP practices, and they are all absolutely bought into, pardon the pun, we are stronger together. That GP federation has, or did have, 1 employee. That was me. I'm the title is business manager. And as I say, that GP federation is absolutely well positioned to start coordinating the projects and the schemes in primary care in the locality. And I've just put this at the bottom just to really start. There's been a few questions that came to Chris, you know, so form and functions of the federations. You know, the Lee Valley Health Federation, the current business plan is absolutely to support primary care. We are looking to consolidate and standardise primary care in the locality, and we want to build resilience. Okay? You know, we're not looking to be the next FTSE 100 company. We are looking to essentially build the foundations of primary care in Lower Lee Valley. So the Federation was tasked to undertake a primary care demand audit. So let's really understand that demand that's coming through to us. And we're not doing it on a practice level, we're doing it across the whole locality. Okay? So we're looking at the demand, the urgency, and the need of people that are coming in. We did it over a 2-week period back in November time. And at the bottom, you know, as you can understand, once we've got the results of that, then we can actually think, well, let's do something about it, or do we need to do something about it? I'll talk a little bit about how we went about doing it. And I've put in red here, and this is a clue. You know, I can't emphasize enough that what I'm going to talk to you about, the reason why it worked is because it was owned by the locality. The locality actually owned this. They wanted it. They wanted to deliver it. I'll talk a little bit more about hiding your practice manager. I totally agree with the practice manager role. So we had an implementation group. We had representatives from all the GP practices, from the minor injuries unit, from the community pharmacies, from the patient participation group. And we also had some external consultancy that helped us sort of consolidate our ideas, draw it into a bit of a plan, and they also evaluated the results for us as well. So what did the audit capture? Well, it captured all the GP reception and telephone team contacts with the patients, okay? It captured all the patient and the clinician opinions about that consultation. I'll come on to that a little bit more detail in a moment. We did it by a survey. We did the same for the minor injuries unit. And we also looked at all the primary care need that was going through the community pharmacies. So I'm not talking about all the patients that turn up and ask for their prescriptions and so on. This is the primary care need in the community pharmacist that says, you know, I've got a cough and a cold, I've got a rash, what should I do about it? The survey form, I thought I'd just put it up there. Yes, it's paper-based, and I'll come on to that in a moment. And it's a little bit historic, but this is the way we did it. Okay, it's a single page of A4. Every single patient that was accessing a face-to-face consultation was asked to complete one of these. And you'll see it's split into 2 parts. It's got a white component and a pink component. The white component was completed by the patient, and the pink component was completed by the clinician. So when the patient came for the appointment, they were said, can you fill that in, and can you give it to your clinician when you have your appointment? So you can start to get the idea that actually we were getting a really sort of 360 picture, both patient and clinician opinion of that consultation, which is some really rich data. We're fairly confident that the data we've got is a fair representation of actually what's going out there in the locality. So yes, we get a really large sample size. We got over 10,000 questionnaires. And again, I'll just go through some of the figures over a 2-week period. All right? That was over 70%. Standard deviation was fairly low. The form is fairly simple. The patients just put a cross in a box. Okay, so standard deviation was fairly low. And like I say, we thought the misrepresentation was fairly low as well. So we're fairly confident to draw conclusions and act on those conclusions based on the results that I'm going to talk about. I have put at the bottom there, the response from the community pharmacists was variable. And there was various reasons for that, but for the purposes of what I'm going to talk about, I've not included those results in the slide. Oh, I've just put this on for a bit of context to give you an idea. You know, to do this audit, we printed out 18,000 bits of paper. Okay, if you stack those bits of paper on top of each other, that's the height of a double-decker bus. Okay, I'll come on to it. I have a little Fiesta, and I'm business manager, I'm operational manager, I'm the doer for the locality. Took me about 3 or 4 round trips to actually get that paperwork to the practices. So for me, that was an important thing to start moving to a digital platform moving forwards. Okay, as I said, we received 10,000 questionnaires. Now, I'll just go back and say, you remember, we support a population of 75,000 people. So if you were to look at the data in a very raw fashion, okay, but in a very raw fashion, you could sort of interpret that as saying, actually, 1 in 7 people in the locality had a face-to-face appointment with their GP practice in that 2 weeks. Okay, now we know that's not the case. It was probably 100 patients having, you know, a few thousand appointments, but actually, you know, that's what it showed. We captured data on the admin. So basically, whether a patient whether they walked into the surgery or whether they phoned the surgery or whether they sent them a text, however they contacted that, we captured that data. And we captured 21,500 data interactions of patients with their surgery. So, and just going back to, I promise we're not going to have death by PowerPoint and data for the next 10 minutes, but I thought I'd just show you some really interesting results because we have talked about it this morning. And actually, you know, this isn't my opinion. This is the results we got, okay, from it. So, you know, the first one, no surprises to you. 79% of people, you know, did nothing to help themselves before they accessed the face-to-face consultation. You know, the path of least resistance is, let's go and see somebody, so let's go and see somebody. All right. The second one. Now, this will be interesting to you. So 62% of people said, actually, I don't mind who I see. You know, we were really surprised at that. We thought we were getting patients coming back saying, I've seen my GP for the last 53 years. I want to see my GP. Well, that's not what the data implied to us. 62% of people said, you know, I don't really mind who I see. Another 20% of people said, I don't know. And it was only 18 people that said, actually, no, I want to see the clinician I'm seeing today. I won't have you telling me who to see. 24% of the consultation activity doesn't need to be seen by that clinician. It can be managed in a suitable alternative pathway. Okay? That's not what the patients are telling us. That's what the clinicians told us. So 1 in 4 appointments could be managed in an alternative pathway. Okay? 3/4 of that 1 in 4 actually could have been managed by somebody else in the GP practice. So just going back to what Heidi was talking about, it's about managing that level of need in the most efficient way. Okay? Now, we've just done a little bit of sort of modelling the way through, and we said, okay, well, if we were to do that, let's look at the GP interactions in the locality. If we were to start doing that, we think we could save about 33,000 GP consultations a year. Okay? When we did this audit, we had fairly low consultations through the phone, only 5%, and the survey, so the clinicians indicated that actually we could lift that to about 12%, and I've not put on there, we can also move it to 9% online consultations, and I'm going to talk a little bit about that as we go forwards. Capacity. Okay, so what are the practices offering? Well, we've got 5 of the 8 practices which are offering more than 80 appointments per 1,000 weighted patients. Okay, so you know, whether you know or not, but the benchmark is about 72 per 1,000 weighted patients. So we've got 5 practices offering significantly more than the national average for GP consultations. And the same was for the nurse practitioners and the nurses as well. This was interesting, the split of the reception. You know, I thought reception was mainly going to be around booking appointments. Well, that's not actually the case. It was about 50-50. Okay, if I'm being honest, it was actually 49-51%. But basically, you know, half of the time the receptions are spent on non-appointment related needs. Okay, you know, anything. I could go through a thing as long as your arm of what they were dealing with, but it wasn't related to the patient's appointment. On the day demand, this was an interesting one. On average, so when we looked at all the practices, the average was about 56%. So 56% of people that phoned up wanting an appointment said, I want my appointment today. And on the whole, practices were really good at managing it. So brilliant. We did a bit of modelling and we said, you know, it wasn't all managed. And I've talked on there and said, you know, you can look at the data, but basically about 12% of people said, no, to be honest, can you call back? There's not an appointment. The impact of that callback is 35,000 extra contacts on the practices. Now, I don't know how your brains work, but my brains work very sort of local, quite a pragmatist. That's big figures. Let me tell you about one particular practice. So we've got one practice in the locality that had a 79% on the day demand. So 4 out of 5 people that phoned up for an appointment said, I want my appointment today. And they did really well at managing that, but they didn't manage everybody, okay? The impact of that was an extra 136 telephone calls to that practice a week, and that's if the patient's only phoned back once. So starting to think about, forms and what's the Federation's functions. We had another practice in the locality that had a similarly high on-the-day demand, yet they had very low. Theirs was actually 20 people had to call back in the week. So I've got 2 practices that are virtually a stone's throw away from each other. One's got this massive high demand, well, they've both got massively high demand. One of them's asking patients to call back to book an appointment, which is just generating more and more work. For what we said is we've factored it up about 136 calls a week, probably an extra day of admin staff. And yet I've got another practice over the road that actually has hardly any. So let's just start learning from each other. MIU data, so no surprises there. If we didn't have the MIU, half the people would go to an A&E or an urgent care centre. About 25% would then go to the GP, and we think if that was the case, we'd probably need about an extra 1.5 GPs in the locality. And again, we've said consistently that the majority of people actually have done no form of self-help, no self-management. They've just turned up for their face-to-face appointment because they can. 38% of the MIU activity actually could have been delivered in a more appropriate pathway. That was interesting. So 4 in every 10. I'll put namely GP. So GP or self-help. Okay? Okay, so that's all very interesting data. I suspect you've all come up with, okay, well, we've all got demand data. It's about what next. And I'll go back and say, Federation was tasked to deliver this audit, so the Federation has been tasked with so what? Okay, so let's just talk a little bit about so what. So what we've done is we've pulled together a primary care development plan within the locality. We've broken that plan into 3 categories. We've got how can we better manage services and access prior to face-to-face consultations, how can we better deliver those face-to-face consultations, and how can we improve the administrative and the sort of back office needs for patients in a GP surgery. Now, how am I doing for time?
5 minutes and we've got 10 minutes.
Perfect, okay. You'll be glad to hear I'm not going to go through all of these. I'll just touch on a few of them. What we've done, the Federation has commissioned a website for all the practices in the locality. Okay, from my research, this is one of the most patient interactive websites, platforms, whatever you want to call it, that there is out there. Okay, this is footfall. I've seen that the team are out there today. Like I say, you can see it's clean, it's crisp, and it's simple to navigate. And as I say, this will offer a phenomenal amount of digital way to manage patients' needs online. Now, I won't go through all of them, but I understand the team are here, so I'd recommend you do have a talk to them today. Behind that website, what we've agreed to do as a group of GP practices is standardise all the practice policies and procedures behind that. So we're starting to deliver the similar service across the whole locality, so we're not going to get patients playing each practices against each other. We're learning from each other. Now, we're not naive enough to think, okay, we'll just set this website up and that's it, we'll all go home and job done. We recognise that patients are going to need a bit of a nudge. Okay, patients are going to need a nudge to use this. They're not just going to suddenly change from face-to-face services, walking into your GP surgery, to using this. Although what has been really interesting is we've rolled this out under the radar and to no fanfare, and we're already getting a phenomenal amount of activity through it. But what we did was we thought, no, we are going to need to nudge our patients to do this, to transform them to do it. So I'm delighted that the Eastern Academic Health Science Network have supported us in this project, and they've funded a dedicated engagement role. So this is a person's role within the locality whose raison d'etre is to get people to use this website platform. Okay, we've only just started it. We're only just at the point of finalising the rollout of the platform. Okay, but that's what we're looking to do. A couple of other things we're doing. Route map of services, very much a patient perspective. Let's give it to the patient so they can start to understand the system to try and navigate it themselves. We're going to be pushing the patient education form around our challenged areas. Cancer screening is a challenge for us. It was really interesting. In the patient demand audit, we saw actually the cohort of patients aged 5 to 15 proportionally was very low activity in primary care. Yet when we looked at the MIU, it was massive. They're all going into MRU, basically. So let's just see how can we manage that sort of cohort better. And let's come up with this sort of, this not practice patient education. Let's do it on locality scale. Okay? A couple of other things we're doing. Delivery of face-to-face services. This is coming into phase 2. I'd love to say we've started it, but we've not quite yet. We're hoping to start it in the next month or two. We are looking to standardise. We're standardising the service that practices deliver and the resource that's behind that. Now, we've taken a rough benchmark of, if we were to say something like 60% GP capacity, 10% nurse practitioner, we've modelled that through to say if all practices were to achieve that, what would that look from a workforce perspective for GPs in the locality? Okay. We've also modelled it, said if we were to drop it to 50% GP and start upping the nurses and what they could do. Okay. We're looking at the common job specifications across the practices. The audit demonstrated there's quite a lot of variance in the scope of the role between the practices. So let's start coming up with common job descriptions across all the practices. And again, we're not forcing practices to merge. We're just trying to standardise what we do. On the day demand and capacity, again, we've got real variance. I've got one practice which has got 79% on the day demand. So 79% of people say, I want to be seen today. I've got another practice that's less than 50%. They're more than happy to plan and book ahead. So we just need to say, okay, for your practice, how can we get transformation of patients to say, do they really need to be managed today? And equally, are we aligning our resource to support that demand on the day? And I put at the bottom, increased consultation type. Heidi touched on it. We need to be looking much more at telephone, and we're looking for 9% online. And I say that's what the clinicians told us. Okay, we can try and move to 9% online. We've got the Footfall platform. If we achieve 9%, I'll be absolutely gobsmacked. But we've got data saying that possibly. Last couple of things. So the admin functions, look, it's no surprise to you. It's busier on a Monday and a Tuesday. It's about 25% busier on a Monday and a Tuesday, and really tails off on a Friday afternoon. And so we need to be going for that generic call handling policy. Going back to that example I used of the two practices, one that's getting an extra 136 calls a week because they're saying to people, can you call back? And the other one booking them in and then not calling back. Okay, so let's just learn, like I say, learn from each other. And I put at the bottom, champion the use of the practice website. We're going to be looking to put actual hardware in the practices, an iPad. So if a patient comes in and says, I want to do something online, I want to chase a referral, find out the results of these tests or whatever, you direct them to the iPad, they can do it all themselves. Nearly done, I'm promised, and then you can go and get a cup of tea and stretch your legs. Evaluation, clearly we need to prove or disprove that what we're doing is the right thing, and so we are looking to repeat the audit over the next 18 months. We're going to do it in a little bit of a phased way, but we will be repeating it to, like I say, prove or disprove, and it is an iterative process. We've not got a plan and say that's it. We're going to be learning at every step of the way. So let's just wrap this up with, so what can I stand here and tell you that I've learnt? I've learnt that yes, there is exceptionally high demand in the locality. Okay, but what I can stand here and tell you is that the data indicated to us that patients and clinicians, and that's the really important thing, the clinicians as well are receptive to change. Okay, because you'll lead a lot of research that say clinicians won't let it go. Well, it indicates to us that 24% of it they will. So I've talked about some of the areas that we can make improvements, and my sort of leaving message is that if you're sat there thinking, well, that's something that we need to be doing in our locality. Again, going back to Chris's slide, whether you're a victim, an innovator, or whether you're an ostrich, these are my thoughts to you. The GP Federation could align itself to really support primary care. Okay? So is it? But it could be. You need dedicated leadership, you need strong leadership. And with anything that's going to come out successfully, you need somebody who's really going to drive it forward, who's operational. Okay? And going back to that slide I put in the red, if you were to do a demand audit across the locality, it's got to be owned by the locality. Yes, by all means, bring people in to try and help you pull the results together, but you've got to own it yourself. Locality ownership, and Heidi, again, I'll support you. For me, practice managers are absolutely key. In my mind, I visualise the practice manager role as absolutely as the crankshaft of change in primary care. If you want something to happen, it's the practice manager that's going to make it happen, and so you've got to get that level of buy-in. PPGs were critical as well. They were brilliant when we were rolling out the demand audit, and they helped us and supported patients to fill out the forms. And yeah, my little survey, my little Fiesta car is going to struggle if we carry on doing it paper-based. So we need to move to a digital platform. And that's it for me. Thank you.